I would like to welcome our viewers to our virtual didactic for SAM 2020, entitled Doctoring in the Sandwich Generation, Practical Advice for Clinicians, Administrators, and Sandwich Caregivers. My name is Maura Kennedy, and I will be moderating this didactic. I would like to thank the Academy of Geriatric Emergency Medicine and the Academy of Women in Academic Emergency Medicine for sponsoring this didactic. We have no conflict of interest to report. In this presentation, you will hear about the current state of caregiving in the United States, tools for identifying caregiver burden. You will hear from emergency physicians who have been or are currently in the sandwich generation. And we are also fortunate to be joined by an eminent chairperson to provide advice on navigating career-related challenges and a social worker with expertise in caregiver support. So what is a caregiver? Simply stated, a caregiver is someone who provides care for another. Often it refers to caregiving for an individual with physical or medical conditions, illnesses, or disabilities. An informal caregiver is someone who provides care to a family member or a friend without receiving payment. Currently, 53 million US adults are caregivers. 21% of all US adults are caregivers. Most of those individuals provide care for someone over the age of 50. And compared to 5 years ago, there has been an increase in caregivers by approximately 10 million, the vast majority of which is due to caregiving for an aging adult. Most caregivers provide care to a relative, 50% to a parent or parent-in-law, 12% to a spouse, 8% to a grandparent or grandparent-in-law, and 6% to an adult child. The mean age for caregivers is 49. 61% of caregivers are women. Caregivers represent all generations: boomers, Gen X, millennials, Gen Z. Compared to 5 years ago, there's a slight decrease in the number of boomers who are providing care and a slight increase in Gen X and Gen Z caregivers. 61% of caregivers work, and despite that, they provide approximately 24 hours of caregiving a week. So what is a sandwich generation? This was a term that was coined in the 1980s by a social worker to describe individuals who were sandwiched between caring for young children and aging parents. At the time, most sandwich caregivers were in their 30s and 40s. Today, most sandwich caregivers are in their 40s and 50s. In fact, 1 in 8 Americans in their 40s and 50s are raising a child and caring for an aging parent. 15% of those individuals are providing financial support for both their children and an aging parent. And the older your parent is, the greater likelihood that you have, currently are, or will provide care in the future. So let's talk a little bit about the impact of caregiving. In this survey by the National Alliance of Caregiving and the AARP, they found that 18% of individuals who are caregivers had high financial strain related to caregiving. 61% reported at least one work-related impact, and 10% actually had to stop working entirely or retired due to caregiving issues. 21% reported feeling alone. Importantly, 51%, however, reported a sense of purpose related to caregiving. There have been many studies that have looked at the impact of caregiver burden on caregivers. We know that caregiver burden is associated with higher rates of depression, higher mortality. And when you look at individuals with dementia and with behavioral and psychiatric symptoms of dementia, if those caregivers have high caregiver strain, those patients with dementia have higher ED utilization, higher rates of hospitalization, and higher overall costs of care. So what do we know about the impact of caregiving and the dual caregiver role on physicians? A couple of years ago, Dr. Yank and colleagues surveyed members of the Facebook group, Physicians Moms Group, and they received over 5,000 responses to their survey. In that survey, they found that 16% of these physician mothers reported additional caregiving responsibilities beyond child rearing. And almost half of that was for caring for ill parents. In their study, they found that physician mothers who had additional caregiving responsibilities had higher rates of mood or anxiety disorders, higher rates of burnout. But fortunately, there was no change in their job satisfaction, risky drinking, or substance use. Finally, I wanted to spend a minute talking about the positive aspects of caregiving. Just as there are many ways of measuring caregiver burden, there are numerous scales and surveys that can be used to look at positive aspects and positive attitudes of caregiving. These aspects include a sense of meaning or purpose, as we discussed earlier, feeling needed, useful, or even appreciated, a sense of personal accomplishment and growth, feeling confident and good about oneself, an appreciation for life and strength in relationships, and finally, resiliency. So what do we know about the positive aspects of caregiving? It may be that these positive aspects can actually mitigate some of the negative health impacts of caregiver burden. In studies that have looked at the positive attitudes of caregivers, individuals with higher scores on positive attitude scales had lower rates of depression and lower caregiver burden. And now I'd like to introduce Dr. Lauren Abbate, an emergency physician and epidemiologist at the Rocky Mountain Regional VA Medical Center and the University of Colorado School of Medicine. She is an associate clinical director at the Eastern Colorado Geriatric Research, Education, and Clinical Center.
Thank you, Dr. Kennedy. I'm going to present some preliminary data from the Cleveland VA Emergency Department for Dr. Jill Hooded, who could not be here today. So the Zaret Burden Interview is a 22-item tool that was originally developed in 1985 to describe caregiver burden among those individuals caring for patients with Alzheimer's dementia. Since then, several shorter versions have been developed and validated in other populations, including community dwelling populations. For example, the short version of the Zaret Burden Interview, the 4-question version, asks caregivers to describe how they feel related to several different areas, including having enough time to spend for him or herself related to caregiving duties, how stressed the caregiver feels in trying to meet other responsibilities related to personal work and family, how strained the caregiver feels when he is around his relative, and how uncertain the caregiver feels about what to do for his relative. And these are scored as never, rarely, sometimes, quite frequently, or nearly always, higher scores indicating more severe caregiver burden. So at the Cleveland VA, Dr. Hooded pioneered the Geriatric Emergency Room Innovations for Veterans program, also known as GeriVet. It's a program that was designed to screen for geriatric syndromes among veterans 65 years or older. It has since been disseminated to several VA sites nationally. Cleveland uses the Zaret Burden Interview 4-question survey to screen for caregiver burden among veterans presenting to their ED. And I'm going to show you some preliminary data where our objective was simply to describe the extent of caregiver burden that was experienced by caregivers accompanying older veterans to the emergency department. So these data are for ED visits that occurred between July 30th, 2019 through May 20th, 2020. We categorize caregiver burden into low caregiver burden, those that scored between 0 and 8 on the Zaret, and high caregiver burden, those that scored between 9 and 16. All of the caregiver burden assessments were performed by intermediate care technicians in the emergency department. Chi-square and t-tests for the differences between categories and means were performed. And as you can see here, of the 112 caregivers who were assessed during this time period, nearly 20%, 19.5%, expressed high caregiver burden. Interestingly, though, caregiver burden did not differ by veteran age, sex, or race. Likewise, caregiver burden did not differ by ED chief complaint. And finally, despite data in the literature, of the 64 people that were admitted to the hospital, there was no difference in caregiver burden. So in summary, about 20% of caregivers accompanying older veterans to the emergency department report higher caregiver burden. However, the severity of caregiver burden does not appear to differ by patient characteristic, reason for ED visit, or ED admission. However, this was a small sample and additional work needs to be done to understand what factors are related to high caregiver burden among those presenting to the emergency department. Nonetheless, the GeriVet program and this study suggests that ED screening for caregiver burden is feasible and may be a useful method for identifying and intervening on those at high risk for caregiver burden. I'd like to thank my VA Cleveland colleagues as well as the veterans who participated in this work.
Thank you, Dr. Abbate. That was really helpful in understanding caregiver burden in the emergency department setting. Now we are going to move to our panelists, including 2 physicians who have or are currently in a dual caregiving role, and a chairperson who has provided support for emergency physicians dealing with that dual caregiving position. First, we're going to turn to Dr. Kathleen Davenport, Assistant Professor of Emergency Medicine at the University of North Carolina, Chapel Hill, and Medical Director of the Geriatric Emergency Department at UNC Hillsborough Hospital.
So thank you, Dr. Kennedy. As she mentioned, I am your sandwicher number 1. So as a brief introduction, and what does that mean? So I have a 18-month-old and a 3-year-old, as well as parents who are 76 years old. And I have been a longtime caregiver of my father. So as a little bit of background, I am the family, they're the baby in the family by 10 years. So I have always been with my parents and been their support growing up, as my sisters were out of the house and in college. My dad is a type 1 diabetic and was diagnosed with bladder cancer when I was in high school. That unfortunately metastasized, and he ended up having his kidneys, his bladder, and his prostate removed, at which point he was on dialysis for 8 years, and we did home hemodialysis. So the dialysis machine was named Iggy. She was a part of our family. And with my mom, I was really the medical support. I always loved being involved. I loved knowing that. And I think as I went through my medical career, I wanted to know more and more because as my dad's journey got more complicated. So my mom is a nurse and was a nurse and worked until she was 70. And so I went to nursing school first, then worked as a nurse for a year, and then went back to medical school. In my post-bac year, my dad actually got a kidney transplant, and then through medical school and residency, and now even as I'm attending, he's had lots of ups and downs, and I've learned a lot from this experience, and I wanted to share with you what I've learned, but also how it has positively influenced my patient care and really affects everything that I do. So the mixed blessing and balance. I think this is an important point. So being a healthcare point person for my family, especially now that I'm a physician, I'm out of medical school, I'm out of training, is a privilege, but sometimes it can really feel like a burden. So on the one hand, I'm privileged because I have the knowledge of the system. I know how the medical system works. I know, what questions people want to hear, and how to navigate the emergency department, how to navigate a very confusing system for a lot of patients and families. However, it definitely can feel like a burden because it's a lot of stress and anxiety. The rest of the family looks to me to make these decisions. And while I feel very confident in my ability to tell strangers or give recommendations to my patients, sometimes it is harder to make those recommendations to my family, and I will struggle with the decisions that I'm making. Am I making the right ones? So what I've done, or what I've really stressed to myself over the years, and what I recommend you do if you're in this position, is remember that you are not your family member's doctor. So you are not responsible, or I'm not responsible for any bad outcomes that happen to my family. I think of myself more as an interpreter of the healthcare system. So I am their consultant. In the end, I'm a member of the team for them. I help them make decisions, but we do it together. And I am their advocate. So I think it's important when you're in the sandwich generation that you are the advocate for your elderly parents. You're not their doctor. And that's really helped me with a lot of the decisions and a lot of the difficult conversations. And I think as I've gone through my career, I now feel a lot more confident talking to my parents about the end of life decisions or palliative care or whatever it is that they're going through, because I think of myself first as their daughter, and then second as a physician and their healthcare advocate. The influence on my patient care is huge. I learned even at a young age that we as physicians don't always listen. We think we're listening, but we don't always listen. Just some anecdotes I've learned. My mom will take my dad to the emergency department, and she will tell the provider, you know, he's altered, he's not himself. And they'll say, well, he can answer 3 orientation questions correctly, so he's alert and oriented, and he's fine, he's not delirious. But my dad can be completely delirious and answer all questions correctly. And what I've learned from this, and having been through this many times, and now as a ER doctor, is I really listen to the family. You know, they know the patient, they know if they're off, they know their baseline, and I trust that, and I go with that. And I think that getting collateral information on all your patients and using the family as your ally is really important. And that just brings me to my second point. The being on the same team with your with the family, especially of a chronically ill or older patient, is so important. So I always ask who's in the room, but more than that, if they have a family member who is in healthcare, I go out of my way to thank that person and to say, wow, your loved one is so lucky to have somebody in healthcare, because you can really help them as an advocate in the system. And I find that that really brings us all into the same team. As a daughter, on the other end, I have found my approach to my dad's care and his care team really affects his experience in the hospital. I have made a lot of mistakes, and by putting, you know, being too involved or trying to give too many recommendations over the phone. So I've learned that, especially now that my parents are out of state and I'm in a different state, that the best way for me to put myself as the healthcare advocate for my parents is to, you know, reach out to the care team, but let them know I'm just calling as a daughter to understand what's going on and to provide any background for you, rather than really trying to interject myself into the care of my dad, since I'm not, you know, I'm not his direct doctor. And I think this has really helped me both when I'm taking care of patients who have physicians or who have nurses or other healthcare providers in their families, and then also as a daughter, I think it has really helped with my ability to be on my dad's team. The other way that this has influenced my care is learning how to talk to patients that don't always stay on target. So my dad is a very talkative and charming, but not to the point. So I've learned to kind of let my dad be my dad, redirect him as necessary, and interject and summarize, which has really helped with, especially taking care of my geriatric patients, appreciating their anecdotes and interjecting at the right time. So if I have any recommendations about maintaining the balance, it's knowing that, you know, you have to understand that mixed blessing and burden. Really try to see yourself as a healthcare advocate for your loved one rather than their primary caregiver or physician, because you're not their physician. And then maintaining the balance of, you know, also taking care of, I can't be there at every hospitalization like I used to now that I have young kids, and trusting the doctors that are taking care of him. And that the last point is just that being a healthcare, having a sick parent or going through this experience can really make you a better doctor. And so use the experience to positively influence your patient care.
Thank you, Dr. Davenport. We really appreciate you sharing your experience and also giving us lessons on how we can take your experience to be better physicians. Next, I'm going to turn over the microphone to Dr. Colleen McQuown. She is the Director of Geriatric Emergency Medicine at Cleveland VA Medical Center and a past president of the Academy of Geriatric Emergency Medicine.
Thank you, Dr. Kennedy. So I am the mother of 3. I have a 3-year-old, an 11-year-old, and a 9-year-old. I live with my husband, who's an attorney and who is completely healthcare illiterate. And I live with my mother-in-law, who is bedbound with multiple sclerosis. I had an interesting journey with caregiver. As a caregiver, I was going through divorce. I had 2 young children, started dating my husband, and met his family. At the time, he had his father with dementia and his mother, who was bedbound with MS, living together, and they had care team during the day. And as a new person to the situation, I'm like, I don't think this is a good situation at all. They're alone at night. He's still driving. He's still managing his finances. And very soon into our relationship, my mother-in-law calls my husband and says, hey, your father is not doing well. He seems to be getting worse. And can you come over? So we went over to their house, and she said, well, Today, all day, he was walking around and threatening me with a gun, saying I've been stealing his money. And at that point, I'm like, okay, we're done. So, you know, this is a terrible situation. And I think the safest thing to do, since he's now asleep and probably has this gun with him, is to call the police and let them help us navigate the situation of getting this gun away from this confused, demented person who has threatened my mother-in-law, who is bedbound. So we called the police. They ended up coming, just talking to him. He gave away the gun and then told them, I want the gun back so I can shoot myself and shoot you. And he couldn't spell his last name, couldn't tell him what medications he was on. So he got transported to the emergency department, placed in geriatric psych. And their recommendations were 24 hours of care, 24-hour day care, no guns, no driving, no access to his finances. And at that point, my sister-in-law was very upset that the police were ever called and has never talked to me since then. So that was many, many years ago. And it really divided the family into who was right and who was wrong about the decision to involve outside of the family care at that point. So fast forward, my husband and I get married. He and my mother-in-law move in with us, and she gets the master suite, and we are down in the basement because she needs the most room. She has 2 sets of healthcare of nurses' aides that come in a day. And we use the easiest way I'd say to deal with having strangers in your house every day is letting go of a lot of what you can't control. And I try to do as much as I can up front with using Amazon Subscribe and Save for all the supplies and having labels on how everything works in the hospital, including things like turn off Keurig when done. And having written instructions such as how to use a washing machine. So fast forward a little bit farther. My father-in-law has died. We've inherited a building, so now we are landlords. I'm pregnant. My mother gets diagnosed with breast cancer, and I lose my job in about a week when the group I'm with loses their contract with the hospital. So at that point, I switched to basically being part-time physician for 2 years, able to take care of my mom, my mother-in-law, and take care of my children. My baby's born. My husband was supposed to be on 3 months of paid parental leave, decides instead to quit his job and go into his own solo practice. So at this point then, 3 days of having a baby, he then takes on a huge pro bono case, which ends up going to the Supreme Court of Ohio, which I'm very proud he won. But we then became landlords, small business owners, and all of a sudden, in addition to being caregiver and parents. And then I suggest that maybe we should get a live-in nanny, like an au pair. My husband is adamant against this. I don't think we should do this. This was before our baby was born. And then as soon as that baby's born, he's like, hey, how fast can we get someone to come and live in our house? So we ended up going with the au pair program. So we had a 19-year-old from Italy come and live with us for a year. And it has been one of the best experiences of my life. It's a lot of work up front because you might not have someone that speaks English that well. You have to get them set up with a bank account, a social security card, and make sure that they can drive. And our first au pair needed driving lessons in addition when she came, but having someone in the house who is like a daughter to me, but is also a helper and who can look around and say, hey, you know what, this maybe could needs a little help. I could unload the dishwasher. I could sweep the floor. I'm part of this family has been wonderful. The other advantage of having an au pair is the flexibility in the schedule because they can work 45 hours a week. I can say, you know what, I want her to work 2 hours on Thursday morning so I can go running. And then I want her to work 2 hours on Thursday night so my husband and I can go out to dinner. So it gives me flexibility. I've been able to volunteer at my children's school because I can schedule that in. And it has really been a game changer for us. And so I definitely recommend having an au pair if you have the room in your house and don't mind an extra person coming and living with you for up to a year at a time. And overall, you know, our lives are crazy and complicated, but having my mother-in-law live with us in some ways is easy because we don't have to go see her. I can go into a room multiple times a day and make sure she's okay, make sure she has the supplies she needs, as opposed to if she was at a facility somewhere else. She gets to see her grandchildren every single day. They can go in and out of her room as they want and visit with her. And it's, you know, in some ways it's easier and it's very rewarding. And I really understand when my patients are struggling with caregiver burden or struggling with scheduling or struggling with a parent with dementia. And I can really understand the hard decisions that families have to make. And my husband and I really use a strategy of humor. When things are completely crazy and things are done by nurses' aides that we had no idea would even occur to them to do, we just pretend that we're living in a reality television show and that we are just players in this reality television show that's for the entertainment of everyone watching. And we also remind ourselves a lot of the Shel Silverstein poem, Helping, which says, some kind of help is the kind of help that helping's all about, and some kind of help is the kind of help we all can do without. And we just say that to each other and smile and move on and let things go. Thank you.
Thank you, Dr. McGowan. We really appreciate the honesty about the challenges and also hearing about how sometimes the important thing is to ask for and accept help and how that can really make a difference. I also appreciated your reflections on some of the career transitions that you went through and some of the career decisions that you made that facilitated providing some care to your mother-in-law. And with that, I'm going to turn over the microphone to Dr. Jane Brice, Professor and Chair of the Department of Emergency Medicine at the University of North Carolina, to provide a chair perspective on how we can negotiate this difficult time when we might be in a dual caregiving role and trying to be successful in our academic careers.
Thank you, Dr. Kennedy, and thank you for the opportunity to talk about this very important topic. As you mentioned, I'm a chair of emergency medicine here at the University of North Carolina, and this is an issue that I deal with all the time. I think most chairs are aware of these needs and issues, but I think it requires a lot of pre-planning and pre-thought, not really on the part of the chair, but together with faculty to think about ways to approach and address the sandwich generation and the challenges that brings to faculty. I think the first thing I would say is that as a chair, you need to acknowledge it, you need to talk about it, you need to normalize it, because a lot of people in the sandwich generation suffer silently and try to make it work without revealing that something's going on in their family that requires their attention. And all that really does is hurt the caregiver further. It also hurts the department though too, because that person is distracted and not fully attentive to the things they have going on, and needs some support and help in order to be able to successfully navigate that. And it's incumbent upon the chair and the leadership to normalize that for the faculty and to make that an expectation, because we all have that problem and we all go through that at some point in our lives if we have people around us we love. So I think it's really important to talk about it and to be open about it. I think it's important to use yourself as an example because, as I said, we all go through this and we all have events in our lives that require our attention and divert our attention away from our clinical duties. I am doing some coaching work, and I was working with one of my clients yesterday, and she said, you know, this doesn't happen to you. You're a chair. You're a very successful person, and I'm sure none of this ever happens to you. And I just started laughing because it happens to all of us, and we need to talk about it, and we need to be aware of it, and we need to make it a normal part of our lives. I also think it's important to say that while it's usually a female issue, as you mentioned in your introductory talk, that 61% of caregivers in this situation are women, that would mean, therefore, that 39% are men. And so I think that we often don't think about our male colleagues as being in this situation as well. And because of our society and because the way we think about gender, they sometimes have even less permission to talk about the issues and struggles that's going on in their lives. So again, we need to talk about it, we need to normalize it, we need to acknowledge it, and we need to make it something that's an open topic of conversation. From an administrative standpoint, I think there are a number of strategies that people could think, administrative folks could think about in order to make this easier for folks and to help them in these times of crisis. One of those is creating or being open to flexible FTEs. So I have a number of faculty who are in this situation right now, and not infrequently they will come to me and say, hey, I can't work 100%. I'd like to go down to 80% just for the next 6 months or so while my this and that is getting out of the hospital or transitioning to hospice or whatever the issue is. And I think that we all as administrative folks need to be open to flexible FTEs and to allowing people to downgrade or upgrade their clinical and administrative responsibilities when events in life happen. I did want to pause and just say that to me, in my experience as a chair, there is a difference between caregivers who are struggling with loved ones with mental health issues as opposed to physical issues or aging issues. And that, what I mean by that is that often when a loved one's relative gets colon cancer, there's a predictable path for the colon cancer. They're going to have surgery. They're going to have some chemotherapy. There's a predictable path. But mental health is a very unpredictable illness, and often there will be events in the sandwich generation's faculty members' lives when they very suddenly have to step away from clinical duties because of mental health issues with a loved one. And you have to be open to that and acknowledge that and be receptive to that. This requires a lot of faculty support and a lot of faculty buy-in, which is another reason to normalize this and to make it a topic that everyone is open to and aware of. And you have to staff the emergency department as though you were going to have someone going out on leave all the time, because you will. And I do have people on leave all the time. And we staff the emergency department expecting that so that it's not an undue burden on those who have to pick up clinical duties. I think you also have to create the opportunity for non-clinical duties. We have one opportunity in our department that allows people not to be in the clinical environment, but yet still contribute to our overall mission and contribute to our clinical effort without being patient-facing. And I think that's because sometimes the cognitive overload becomes just too great to be able to take care of your mother and your twins and your in-laws and take care of patients in the emergency department, particularly during COVID. And I think it makes it really hard from a cognitive perspective to be able to manage all of that and still feel like you're safe in the emergency department and taking good care of patients. So creating non-clinical duties provides the opportunity for people to still contribute, but to step away from the clinical environment during those times. I also think you have to create policies and support efforts to be able to support faculty who are struggling with caring for their loved ones. And we've done that in our department in two ways so far. One is through a parental leave policy that we have structured just for our department, which allows, I think, a relatively generous opportunity for both women and men who are becoming parents to be able to structure their clinical workload such that it meets their family's needs and allows them to be home at times when they need to be to take care of newborns or adopted children coming into their homes. We've also done this with a sabbatical policy, which allows people to work when they work additional shifts to pay them into a sabbatical bank, and then to be able to step away for a period of time from the clinical environment, having already pre-worked the shifts that they owe for their clinical duties, and be able to spend time with loved ones or family at particularly important times, such as the death of a parent or a loved one, and to be able to provide support in that way. I also think as a chair, it's really important to do frequent check-ins and to be talking to people about what's going on in their lives and to be open to those conversations, and to encourage those conversations, that it's okay for you to talk to me about your mother who's now in hospice and not doing well, and that that's requiring a lot of your attention or needs, or to talk to me about your special needs son who is having lots of issues and troubles. It provides an opportunity to hear what's going on and to offer support, but it also provides an opportunity for there not to be surprises. Like as a chair, the last thing I need is for someone to walk into my office and say, I'm stepping away for 6 months because this, and this that I had no idea about. And so it provides the opportunity to pre-plan for events and to provide structure and support for faculty members who are struggling with those issues. It also prevents misunderstandings about what's going on, and allows you, as I said, to pre-plan and to be prepared for those issues. And lastly, as a chair, I think that it's really important that we advocate at the institutional level for these kinds of policies and changes in perspective. I think sometimes a big institution forgets that it's made up of people who provide the services that they're billing for and that they're running on, and bringing that forward and reminding people and advocating for change and support at the institutional level, I think, is critical. So I think there's a lot you can do at an administrative level. Most of it is about relationships and about people, about talking to people, about sharing your own experience, and about normalizing caregiving. But I think it's super important at the administrative level to be offering those services and having those thoughts and conversations. So thanks for the opportunity.
Thank you, Dr. Brice. I really appreciate your perspective. It's really amazing to hear about your planning for the things that we are not planning for, and also take some of our mental strain and guilt away when we know that our chair is already anticipating that their faculty may need some flexibility and support.
Yeah, so I'll just add that most chairs are older folks, me included, and we've been there and done that. And I think that you just have to remember where you came from and what it's all about and help people out.
And transitioning to helping people out, I am going to introduce Susan Rowlett, who I am fortunate to work with here at Massachusetts General Hospital. She is a licensed clinical social worker, and she's the program director for our Dementia Care Collaborative. And here, she's here to join us to share practical tips to help us in the dual caregiving role.
So thank you, Dr. Kennedy. It's an honor and it's a pleasure to be here with you today. So what does it mean to be a caregiver in the sandwich generation? It really is navigating life between our parents, an older person that we're caring for, ourselves, our children, and also our work. So it's not easy and it doesn't come naturally. So there's a lot to learn. So care tasks are many, and I think people don't recognize all the things that they're doing because they're just going through the motions. I like to sort of have a visual for all the things that we're doing so you can really take it into consideration. Household tasks, as you know, if you're already caring for one household, sometimes when you take on caring for an older adult or a parent, you're taking on another household to care for. The next piece is the activities of daily living, like bathing, dressing, going toileting, and the hands-on care is what causes such physical exhaustion. The emotional and social support, people don't realize that you have to show up and try to be calm and try to be patient and making sure that the older adult doesn't become isolated. The health and medical care piece of it is huge. You have to know all the different doctors, schedule the appointments, make sure that it works around your own schedule and your children's schedule and your work schedule, managing medications and follow-up, advocacy and care coordination. So I'm really encouraging people to bring care in, but how do you manage, schedule, make sure everything's going okay? And the last part is just being a decision maker. Stepping into the role of making a decision for your parent. And that could be about something like driving, about where they're going to live. These are huge decisions. And if we haven't, so there's a couple things I want to say about that. If we haven't talked about it beforehand, before we have to make these decisions, it is very, very hard and stressful and can have long-lasting ramifications. So 4 ways to balance the responsibilities of parenting and caring for parents while you're also working. I really cannot encourage communication enough. Having a series of conversations about values and wishes related to aging and illness. Nobody wants to have these talks. My parents do not want to have this talk with me, though I have this with hundreds of other families. But if you're in a family like mine, you really have to be intentional about making sure you have this conversation before crises happen. And you want to enter into the conversation with realistic expectations so you don't get frustrated with yourself or with the people you're talking to. We want to think about if someone were to become ill, if someone needed care in the future, what would living arrangements be? Are we planning on hiring professional help, or is there an expectation that the one daughter is the primary caregiver, and is that okay? If it's not, you need to talk about it now. What are the financial resources to pay for care? Do we have all the medical and legal paperwork together? Who are the decision makers? Making sure that everybody is on the same page about those things will save so much distress and emotional upset if that is not decided ahead of time. You also want to share your own fears and concerns and listen. Be organized before you go into one of these conversations. It'll really help you to meet the goals that you want to accomplish, but you also have to be compassionate that even if you meet one goal, that's probably a successful conversation. Offering the opportunity for siblings to feel included and share in the responsibilities as best they can. One of the things I do as someone who consults with families about caregiving is I often figure out there is often something that a sibling who maybe lives far away can really help with, except that we're all going to have lingering emotions, and that may affect our ability to cope. We want to try to find ways to forgive, and not just for your parents' sake, but for our own health and well-being. So this is going to be mentioned multiple times, so this is the take-home message, is to not do this alone. We really want to think about who in your life can support you in your responsibilities in this area of your life. And thinking about expanding who you would normally include in helping you with a family issue is really an important thing to do when you're thinking about what caregiving that often goes on for many years. So it may be your spouse, siblings, children can help, professional caregivers, the physician, the nurse practitioner. Many doctors' offices have social workers. There are social workers in the community. Thinking about extended family, even if they can be friendly visitors or offer to cook a meal or visit on occasion. Including friends in ways that you don't want to overburden people, but there may be things that people would be happy to do for you if you ask. And thinking about your faith community. What do they offer to elders in our community, and what might they offer to your family? So I think the key to this is asking for and accepting help with what you need. Hiring outside help is also providing care. You are providing care. What you promise to do is care for someone, make sure they are healthy and well and happy and have everything that they need, and that might have to include outside help. And you are being a caregiver by providing that outside help. You need to take a break and have some me time scheduled into the week, and we'll talk some more about that. Number 3 is determining your benefits at work. Really appreciated Dr. Brice's presentation on how wonderful an employer and a boss can be, and understanding how important communication with your employer is ahead of time so that they are able to help you in any way they can. I also want to just reinforce that employee assistance programs have a lot more to offer than I think we often realize. So definitely check to see if there is an EAP and if they have an elder program that includes referrals to caregiver resources in the community. Many of them have on-site support groups for working caregivers. We do that here at MGH. All of our groups are now virtual and easier for people to get to. They may even have relationships with companies where they can provide discounts for care. And what's more, thinking about arranging a more flexible work schedule for you that allows you to deliver on all the areas of your life where you're trying to be your best. So the next part is to put yourself on your to-do list. Of course, we want to be there for the people we love, but it is draining. We can't sugarcoat that. And when we're left drained and exhausted, what can we possibly give to others? There's a lot of data on caregivers that talks about the physical and emotional toll, but also a financial toll, which is such a stressor for us all, that we have to take it seriously and we have to put ourselves on the list somewhere. It would be great if you're first on the list. That's what we would hope for. But as long as you're putting yourself on the list during the week to do something for yourself and to make sure you're tending to your own needs, that's what we're talking about here. So the next thing that I want to talk about is navigating this very complicated elder care system. As a caregiver, you end up interacting with a lot of different people. Figuring out how it all goes together and who to call for what can be a full-time job in and of itself. So I want to mention one particular resource that can help you manage all of these things. And I can't state how helpful they can be if you have the resources to hire them. I want to stress the importance of the care manager role in the system of care. They are experts in elder care. They're on the ground dealing with care providers. They know which facilities are doing a good job, which home care agencies are good, really everything you would need to know. And you don't have to figure it out all yourself if you can hire a care manager. So they're privately paid. They can do anything from helping you get started, providing you with what the options are for care. They can do a full assessment and make recommendations about what services might be helpful to you. Or they can go all the way to managing care completely for someone who may not have a caregiver who is local. They can be an emergency point person and provide everything that someone would need. So I'm going to leave this with resources. And again, the take-home message is that you are not alone. You do not need to do this alone. You shouldn't do this alone. So remembering the EAP programs, the employee assistance programs, and employer benefits. There are area agencies on aging in every state. It's a federal program that it's administered individually by states, so the programs differ state to states how they use that money. So you can go to this website that I've provided and find the area agencies on aging in your area. They will give you access to home care, to Meals on Wheels, to transportation, and really referrals to any resource that is available in their community. The National Association of Elder Law Attorneys, I think that when we're planning for illness and care for late in life, that an elder law attorney knows a lot of ins and outs of law that are really important. So if you've already done legal and financial planning, you might want to just run it by an elder law attorney to make sure you've covered long-term care planning, Medicaid planning, and those kinds of things. And this website provides a lot of information about documents that you need for legal planning, but also connects you to elder law attorneys in your area. The Aging Life Care Association is the professional organization for those private care managers that I mentioned before. This website will give you a lot of information about what they can do for you, and you can look up care managers in your area and get their contact information. And then disease-specific organizations, the one I'm most familiar with and the one I work with most closely is the Alzheimer's Association. They have a 24-hour helpline, and their website is full of information about every question you could think of asking. So with that, I'm going to finish. And again, Dr. Kennedy, I appreciate the opportunity to be here.
Susan, thank you so much for that. I think there are a lot of nuggets in there that are really important. The idea of a care manager, someone to bring in early to help you for the planning. It's not something I have ever heard about or learned about. As physicians, we learn a lot about disease processes and treatments, and some of these support elements we just don't know about. So critical to finding the people who can support you and can direct you in that location. With that, I hope all of our viewers are doing well. And hopefully we will see everyone at SAM 2021.